All right, let's get started today. I'm Nancy Baxter. I'm the head of the School of Population and Global Health at the University of Melbourne. And I'm very, very pleased to be hosting this webinar today that's going to introduce you to a new web-based tool called the COVID-19 trade-offs tool developed by Professor Tony Blakely and his team here at our school at the Melbourne School of Population and Global Health. Before I begin, I would like to acknowledge that I am on the lands of the Wurundjeri people of the Kulin Nation, who have been custodians of the lands and waterways of this region for thousands of years and many generations. I pay respects to their leaders, past, present, and emerging, and I look forward to our shared future together. I also acknowledge the traditional owners of the land on which you are on, and I ask you to spend a few moments reflecting on that. Well, today you're going to see a new research tool that is tremendously exciting. And it's been made possible by an anonymous donation to the university for this work, which was really essential to actually being able to accomplish it. The team that made this happen include the Transport Health Urban Design Laboratory at the Melbourne School of Design, Dr. Jason Thompson, who built the original agent-based model on which this the core of this, Professor Stevenson and McClure, who assisted Jason back in 2020 to develop the model, and now Dr. Haifeng Zhu and Sashinth Senavarante. You are really made this fly on a supercomputer, so we're now able to do the calculations and the permutations much more rapidly. We also have the population interventions team that are really making this work. Dr. Tim Wilson, Dr. Drisait Ukrum, Dr. Lashman Bablani, Ms. Amira Kata, Dr. Natalie Carvalho, and Dr. Patrick Abraham. And finally, but far from least, Dr. Luke Thorburn from Hunt Lab for Intelligence Research at the University of Melbourne, who created the wonderful web tool itself, which you're going to see is just tremendous. To tell you more about the tool, I want to introduce Professor Tony Blakely, who needs little introduction to most of you. He's an epidemiologist and public health medicine specialist at the Center for Epidemiology and Biostatistics, author of the roadmap that helped to get Victoria out of its lockdown and quash the pandemic for us, getting us to this wonderful state that we're in now with elimination. Tony.
Thank you, Nancy. Welcome everybody today to this webinar. Those are just acknowledgements of the people that Nancy's already mentioned, so thanks for that, Nancy. So what we're going to do today is we're going to have a look at the tool. We're going to have a look at some slides where we've lifted what we think are some of the key findings from the tool, our interpretation, which may not be the same as yours. That's why we've provided the tool so that you can go in there, have a look and see what you think. And then we'll talk about what's coming next. So just to remind you, we've got a vaccine rollout happening. At the moment, we've just hit into stage 1B here. And then it's going to move on into phase 2, where it's largely adults, phase 2B, where it's the rest of adults. And I'll be presenting some results later on just for phase 2B. And then if we get to children, phase 3, and I hope we get to children for reasons that will become clear. Now, when you go into this tool, we've given you options to look at, and there are 5 switches like this. So you can pick the level of vaccine uptake you think that we will achieve in each phase. You can pick whether or not the strategy is going to be relaxed or not. By that, I mean, we're going to have, I'll show you the options in a sec, but if it was, say, moderate elimination, we could relax the thresholds over time as the vaccine coverage increases, or we can hold them at the same. These 2 ones here, the vaccine efficacy, are not what you normally see talked about in the media. This is not the effectiveness of the vaccine stopping me getting particularly sick. It's the effectiveness of stopping the transmission. So it's the percentage reduction of somebody who is unvaccinated getting the infection from somebody who's infected and unvaccinated all the way through to somebody who is vaccinated but still hasn't had a natural infection, contacting somebody who happens to have got infected despite the fact they're vaccinated. And I'll come back to that later on. The last one down the bottom here is really important. This is the reproductive rate, the number of people that one person would pass it on to if there were no controls in place. And the default is 3.125. It's normally 2.5 last year. This year it may be even higher. And we'll have a look at that in a sec. So those are the default settings there that you see in red. Now, I said we've got 4 scenarios. Every time you hit one of those switches, 4 scenarios will come back at you, and we've named them aggressive elimination. That's pretty much what New Zealand did last year, and also Victoria coming out of the second wave. We aggressively went for elimination. Moderate elimination might be more what New South Wales do, whereby they go into a lockdown a little bit later, come out a little bit earlier, and rely more on their contact tracing. Tight suppression is perhaps what South Korea or Singapore does. They decide they can't achieve elimination, so they try and hold the numbers really low. Loose suppression is what Europe was doing before Christmas. So they were living with the virus before it really got out of control going into Christmas. So just to give you an idea of these relax, not relax triggers, there's a lot of triggers in the model. I'm just going to show you one, the important one, which is going into stage 3, which is when you sort of move out of community controls and into something that looks like a lockdown. And you can see here, we've got the numbers. That's 0.23 cases per million. So it's a very aggressive threshold before you go to stage 3. But for loose suppression, you'll be waiting for 50 per million in the last 7 days, average daily case, or 2,310 across all of Victoria in the last 7 days. Now, if we put relaxation switch on, then these relax. So if you look at moderate elimination, you can see we start there in phase 1, we relax in phase 2A, relax more in phase 2B, each time it doubles until we get to that sort of threshold. So by the time in tight suppression you're down here, you'll notice that these triggers are much the same as what loose suppression was at the beginning. So that's what the relax switch is about. Right, I'm now going to show you briefly the tool. I'll need to unshare my screen for a sec and then reshare my screen. Okay, so you'll have a link to this tool at the end of the presentation. And what you'll see is you'll come into a page like this, and you'll see these switches across the top here. I'll talk about the stuff coming soon towards the end of the presentation. But the main thing today we're going to look at is the infections and health impacts. You scroll down here, and then you see those switches I was showing you before. And then you start to see some of these graphs that we'll look at a bit more closely together with the PowerPoint. But notice it's interactive, so you can see what the numbers are. You can choose what scale to have. You can choose whether it's linear. At the moment, it's linear on the y-axis, or non-linear. It's an exponential scale. And you can also say, oh, we'll never do loose suppression, and unclick it and just see the rest, and then do things like depend on the data so you can see more what's happening. Further down is this part here, whereby the results above here are just the average across 100 simulations. And down here, we'll show you all 100 if you want to have a look at them. This might be useful if you're the chief health officer, for example, and you really want to know how many times the numbers go above, say, 100 a day or something like that. It's color-coded. The red means that you're in stage 3 or 4, so you can see what stage your state or jurisdiction is in. And then the last bit we'll look at today is the health outcomes. So we've basically gone through here, we've done an extensive international review. We've identified those diseases and conditions that are associated with lockdowns independent of there being a pandemic. And we find these ones to be associated here, and we then look at the net effects. Right, I'm going to take you back to PowerPoint now, just for a bit of stability. I'm just resharing my screen. All right, let's have a look through some of the results. Okay, so there's what graph, the default one you'll see when you go on. And you can see there, we've assumed that the vaccine uptake is 75%. We're relaxing the strategy as time goes on. We have vaccine efficacy, 75% of how much the vaccine will reduce transmission, and about an average. So average between what the reproductive rate was last year and what I think it might be now. I think it's personally a bit higher than this, but that's up to you to decide when you use the tool. The solid lines there are the average of the medians across the 100 simulations. But you can see for loose suppression, there's huge variation here. This is the 5th to 95th percentile of what's happening at any one point in time. And that is COVID. It's stochastic, it bounces around. So we've given you the range as well as the average. You can also see here that you can't even see the elimination ones because they're keeping the numbers very low. So here's a pessimistic scenario. Here I have set the uptake at only 60%. So that's if vaccine uptake is only 60% in each phase as we go on. I hope it's going to be better than that. The relax switch is on, so we're releasing the triggers over time, even though we haven't got high vaccine coverage. The reduction in transmission is 75%. that transmissibility reduction, not the protection of me to go into ICU, but the transmissibility reduction of me passing it on and another person getting it. And this is for what I think, and not everybody agrees, that I think the reproductive rate might be for something like the UK variant at the moment. So the one that's in Brisbane at the moment, maybe not quite as high as this, but somewhere up around that now. And you see it's pretty ugly. I've now got a log scale here. There's 1,000 cases. So if we went straight to loose suppression, we'd have an expectation of 1,000 cases at various points in time. Tight suppression is still not looking that great. It's down here around 100 and bobbling up, and you can start to explore these. So that's a pessimistic scenario. This is my best guess at this point in time, and you can form your own best guess when you go into the tool. I think we'll get vaccine coverage up around 75%, is my guess. I also think that reduction in transmissibility will be greater at 90%. And I believe that to be the case because I don't think people have clocked on to the fact that when I take the vaccine, it protects me from getting it, but it also means over time, as more and more people are vaccinated, the people who are unfortunate enough to get infected yet be vaccinated will be infected for less duration with less peak infectivity. So I think this will be quite high, but I do fear that the R0 is going to be 3.75. So for my personal scenario, again on a log scale, loose suppression still looks pretty ugly. Tight suppression is looking a bit better. And you can see down here for the two elimination ones, they are keeping the case numbers on expectation less than 10 the whole way through. So that's not bad. Maybe things will be even better. We'll hold the scenarios and we won't relax them because we'll just keep, the level at which we go to lockdown the same. And maybe by some miracle, in my view, we'll have the old version of the virus only circulating in Australia. And you can see any strategy will work at that point. But I think that is unrealistically optimistic. So what about the effect of vaccine uptake? Because that's one thing that we can control, or at least try to do well with our vaccine rollout. So there's the default graph. You've already seen that. I've just clipped it a little bit. And let's see what happens if you go to vaccine uptake of 60% there. You'll see things blow up quite a lot, particularly out here, because remembering that the vaccine coverage from these first phases impacts upon how well things are going by phase 2B, which is when adults are vaccinated, and phase 3, which is when I hope children are vaccinated. But if you get 90%, it's looking tickety-boo. You can see that that high vaccine coverage in these first two phases will really put us in quite good shape towards the end there. So, unsurprisingly, vaccine coverage matters. Now, you can play with this tool, and I encourage you to do it. Here is my attempt to try and summarize everything in one slide. This is a heat map. It's for 216 scenarios. I dropped those where the vaccine efficacy was different between phases and just assumed the vaccine efficacy was the same across all phases. And I get this heat map. This is for the old variant, perhaps the new variant, and perhaps the new variant now if it's more effective than what we fear. And over here, we can see whether or not we're relaxing. No, yes, no, yes, no, yes. And then decreasing vaccine coverage and decreasing effectiveness of the vaccine at reducing transmission. Green is good. So these are the average weekly per week number of infections in phase 2B. So when people like me and younger than me adults down to 18 are all being vaccinated. So this would be about maybe August, September this year. So you can see any of these scenarios is quite good. If we accept that the virus that could get into Australia is going to be somewhere around here, we want to be looking in this zone. Loose suppression looks too ugly. We shouldn't be going there. Even tight suppression, those numbers are getting pretty high per week. I don't think a chief health officer and a premier would be particularly happy with that. But it does look like in this area of moderate elimination and aggressive elimination, even when you're relaxing a bit, those numbers there are probably okay, maybe a little bit dodgy there. But have a look at this. This is the infections now. Watch this. This is the proportion of time that we would be in a stage 3 or 4 lockdown. So soft or hard lockdown. If you think about where we're looking at on the previous messier now, colors are messier, because you'll use lockdowns and aggressive elimination, but in loose suppression, you'll need to use them because things get out of control. But if you look where we were looking before, it's not so easy. We're even up to 50% of the time in lockdown in this corner here, when we've got poor effect of the vaccine. I don't think it'll be that bad. I think we should look down this column here at 90%. And when the strategy relaxation. So you can see it's going to be a delicate balance of what we do as far as the lockdowns and the opening up for borders and that sort of thing. Right, so the net health impacts. We know that lockdowns are necessary and they work, but they also probably have well, probably they do have unintended health consequences. The right balance is going to change over time. As vaccine coverage goes up, we can probably loosen up because we won't have as much harm from the COVID virus because there'll be more protection, but also those people who get infected, even though they're vaccinated, will have less harm themselves. Now, we did an extensive international literature review. We found all these things to be associated. There's probably more than this, but the ones that we could find decent evidence on. And at this point in time, these blue ones are in our tool. And this is what it looks like for my preferred strategy. So here we go, the settings down here, vaccine uptake 75%. We relax the strategies. Success at reducing transmissibility is 90%, but the R0 is ugly, up at 3.75. So worst by far is loose suppression with all this health loss down here in health adjusted life years. The majority of it being due to COVID itself, not surprisingly. But look at this over here. On aggressive elimination, you see quite a lot of health loss in orange because of depression and red because of anxiety. So these are our best estimates at this point in time. Expected, we'll be building in uncertainty about these because there is genuine uncertainty. Notice road traffic injury goes down, so therefore you get health gain when you've got lockdowns, but it's not enough to offset what we think is the likely depression anxiety effect. But the thing to notice here is that moderate elimination looks pretty good on reducing health loss and being a compromised position. So we encourage you to make your own interpretations, and here are ours so far that you may or may not agree with. So the likelihood of future uncontrolled outbreaks, unsurprising this one, not rocket science, is considerably greater if we adopt a loose suppression approach. But the risk varies markedly with the R0 of that circulating variant. And this really gives us pause for thought with what's happening in Brisbane at the moment. Brisbane really does need to squash out that outbreak because it's the UK variant up there, and it would be not pretty if it got away from us. An ongoing aggressive elimination strategy, as per New Zealand and Victoria into 2020, I was an advocate of this then, but as the vaccine coverage goes up, is probably not going to be our optimal way forward. And we need to think about viral incursions from overseas. We actually don't want that virus getting in until we've at least got most of the way through vaccinating the adults. Again, think of Brisbane now. We really need to hit that hard. Now, we will explore border options more explicitly in this tool and give you switches for that in about a month's time. At the moment, we've got a lot of uncertainty about how many people get into the population at each point in time. That grows over time. It's kind of hidden in the uncertainty. We'll pull it out as a switch that you can control in the next month or so. Now, our model, we've modeled the children being vaccinated, but we know from some good colleagues, Zakrazin, Prapakenko, that if you don't vaccinate children, unfortunately, we will not be resilient. We won't be achieving that sort of idea of herd immunity. So the discussion we're going to have mid this year about vaccinating children is critical. So what next? Well, we'll be evolving that web tool to include specific options for border openings, as I've said. Build in the uncertainty about those health impacts. Add in net health expenditure and GDP costs. So we're going to bring in the cost part, the economic part, so that we can see those as part of the COVID-19 trade-offs. And we'll include a cost effectiveness tool, which will give you an optimal approach from a cost effectiveness perspective. There are obviously many perspectives here, but using those costs, those health gains and everything else, and try and come up with what would be optimal purely from putting on your health economic hat. And we'll be updating inputs to the model as our evidence base globally and in Australia improves. So you can find this tool at this website, and I think it'll be dropped into the text now, into the chat, so that you can see that. There'll be this PowerPoint will be up at that place as well as on our population interventions website in due course. Right about now, there should be a piece being launched at the Pursuit, so the University of Melbourne's scholarly blog, if you like, the equivalent of a conversation. So if you just go to the Pursuit, you'll find a summary of what you've just seen today. And if you go to the population interventions unit, the unit I head, there'll be other information going up in due course. So Nancy, with that, we'll take questions and answers actually. So
we've got well, I'm just trying to start my video again. We've got a few questions, Tony, in the Q&A. What are the implications of this for Australia and worldwide?
Yeah, great question. So this model was done with Victoria because we have good data from the second wave of what the mortality, the morbidity and all those effects are. But essentially, I'd be quite happy to say that this applied to New South Wales, to Tasmania, to Northern Territories, to Australia, maybe also Taiwan, other countries like us. Now, what we did in this model, I should have mentioned it, my apologies, is we seeded it with 6 infections. So it's like we stress tested the population with 6 infections, exactly what's happening in Brisbane now. So it'll be useful for those places. Now, if you were sitting in South Korea or in UK at the moment, you'd have to think a bit more about this tool. You'd look at the loose suppression and you can make some inference about that. And we may be able to run some models where we start at a higher infection rate. But essentially, for any of the 9 states and territories of Australasia, including New Zealand, this is applicable. Next question I see, Nancy, is the main thing.
The main thing I would want to control is the speed of the vaccine rollout. So this is something we're all concerned about. It's currently around 10% of the target pace. Hopefully it improves. But the phase plan as presented seems unrealistic. So how are you including that type of thing in your modeling, Tony?
Okay, so yeah, we all want this to happen quicker, but not so quickly that we stuff it up as well. It's a delicate balance. So you'll see on those graphs, we've got the phases there, and they take 50 weeks, I think, at the rate that we did. Now, at the moment, it's not going to happen in 50 weeks unless we do really well. So you just need to, in your mind, stretch that axis out, and probably in your mind, stretch out 1A and 1B to be longer there. Now, if the rollout doesn't pick up speed, we can rerun this model with longer time in there, because that would see more time for an outbreak to take off. But at the moment, you need to treat our x-axis, the time, as like a sort of, not qualitative, but a guidance tool. It's not exact, but it should be reasonably good for working out what's going on. Now, obviously, like everybody else, I want to see the vaccine rolled out quicker. So we've got another question here.
Yeah, so there's 2 questions here. What is the currently known reduction in transmissibility as a result of the AstraZeneca vaccine? Another question we'd all like to know. So that's the first question, Tony. And I guess how might that influence your modeling?
Okay, this is a great question. I'm going to go a bit geeky for a sec. All right, so the AstraZeneca does its effect to protect people against serious illness. Very, very good. It also reduces transmissibility, because we know that from the UK study where people are self-swabbing every week or so after being vaccinated. Now, initially, those estimates were very uncertain, but it's starting to look like it's 70 or even 80% reduction in the chance of me, if I'm vaccinated, getting it from somebody out there who's infected and unvaccinated. But you see, it's better than that, because once the vaccine coverage goes up, those people who happen to get infected out there who are vaccinated, because it will happen, will probably have a shorter duration of infectivity and less peak infectivity. So I'm actually quite confident. I realize that I don't believe I'm on a limb here. I think it's correct to say I'm quite confident that the effect of the vaccines on reducing transmissibility will be quite good, including AstraZeneca. There's always a but or an except if we get vaccine variants breaking out, which really are resistant to the vaccine. That is the big fear here, and we haven't explicitly included that in the modeling. We may do that in a few months' time if we start seeing vaccine variants breaking out, which really do not perform well with the current vaccine. So I hope that answers your question. And then it's got a second part, hasn't it, Nancy?
Yep. Am I right in thinking that this model assumes that the virus does not acquire vaccine-resistant mutations? I think that's what you've been talking about. Any ideas about what to expect if it does acquire mutations? And maybe that's an important thing to consider in your model, Tony, because, you know, I think predicting worst case scenario may be important in terms of, you know, ensuring that everyone in the world gets this vaccine.
Okay, this is a great question. I nearly put another slide in this morning to this. So let's talk to it now. Remember, there was the switch on the R0, 2.5, 3.125, 3.75. So if you pick the 3.75 for a UK type variant, and if it really is going to be bad, then lower the reduction in transmission down to say 70% or so, because it would, you know, that would be the lower case, I think, of what might do for the vaccines with variants. If you do that combination, you will really get a worst case scenario and will give you some idea of what might happen. So basically lower the transmissibility impact of the vaccine to replicate viruses coming through that are more resistant. It's not pretty to look at, I can tell you now, but it's there for you to explore should you wish to.
And I think this might be a related question about the South African variant in terms of, you know, another variant that may have different properties or different are not.
Yeah, so we hope we've covered the range for you. So the 2.5 is in there for the variants of last year, and they're still around, but they're going to get displaced. 3.125, 3.75 probably cover the range of the current variants. we haven't put in something like up above 4 for maybe in 6 months' time. And I don't wish to say this is going to happen, but if the worst case plays out and we get even more infectious variants, then we will put that into the model. But that's not the case at the moment. 3.75, I think, is a reasonable upper limit on what the R naught is for the current variants of concern.
So this is from Alison Morgan, who left Melbourne and went to Washington, D.C. Can you use this model where the scenario starting point reflects a setting with overwhelming community transmission? So Alison's in D.C. now, where current community infections are 17.6 per 100,000.
The answer, Alison, is yes, but we haven't done it yet. So we could easily start this model out as though 17.6% of the population have been infected, put proportions on them of those that are proportionately likely to be reinfected. So, for example, we know some people being infected will be reinfected. We could do that. We haven't yet done that. If there's interest in this type of modelling from outside of Australasia, easy to do.
Someone's asking, and I'd be interested to hear, Tony, what are your predictions for Brisbane?
It's on a knife edge. I am concerned about what's happening in Brisbane. Last weekend, I thought, let's do a quick short lockdown to get on top of it because Easter's coming up and then we can open up for Easter. The situation's changed. It's quite concerning. What our modelling shows is that if you don't get on top of it and stamp it out when your vaccine coverage is not up, we have a problem. So all power to the people in Brisbane, the medical staff there, the contact tracers, to really stamp this out, because you don't want to have it circulating in the community. I don't have a stronger prediction than that, other than to say that I am concerned.
You know, on Tuesday, I was out for dinner, and the first time I've eaten at, the bar since all of this happened, and it was pretty crowded. And I was thinking to myself, maybe that's the price that we're going to have to pay, is to, every 3 months go into a 3 to 5 day lockdown to be able to live in this kind of, as if COVID doesn't exist, because that's basically what we're doing now. We're living as if COVID doesn't exist. And maybe that's just the price of it until we're fully vaccinated.
Yes, when we were doing this modelling, I was starting to get complacent myself and thinking we're all tickety-boo. But actually, it doesn't take long for the virus to get out of control. I do think, I'm not going to say fear, I predict that we will be having more lockdowns, all of us, between now and when the vaccine coverage is very high. It's an unfortunate reality. It is a reality.
Well, and maybe we just need to think about it that way. The lockdowns allow us to have free and full life in between. So could you talk about how you will incorporate border control considerations? This is an interesting one. The scenarios currently assume ongoing, very tight border controls. Are we assuming that they will stay that way forever, even if other countries' vaccine levels are equally high?
Anonymous attendee, great question. At the moment in the model, what we do is we assume that about 1% chance per day of a virus coming in, which would be the equivalent of what's been happening with quarantine failures in Australasia at the moment, about 1% per day in each of the state and territories. In the model at the moment, we increase that up to about 16% by the time we get all the way through to vaccinating kids, to approximate some sort, we don't know exactly how it would look, loosening of the borders. That's behind the scenes at the moment. It doesn't just go up 16%, it has wide uncertainty about it. So what we've done is we've put the border options in the model at the moment with wide uncertainty because we don't know. What we're going to do in the next month or so is pull it out of that uncertainty and give you, the user, some options about whether you want tight border control going on, moderate, or opening up. And then we will tell you what type of interventions would achieve that. We won't model explicitly whether or not you're wearing masks on the plane, yes or no, whether you're vaccinated on the plane, yes or no. What we'll say is for these types of scenarios, you would pick moderate border control. For these types of scenarios, you'd pick tight, and then you can see that. That's what we're planning to do.
Does your model indicate at what point officials can ease current suppression strategies, and when we can see states relax their mass isolation, contact of contacts, etc. strategies?
G'day, Tom. Yes and no. At the moment, it's a bit more qualitative because we know what's happening behind that model, and we can say, I can look at those outputs and I can say, by the time we've done all the adults, we can really start loosening off on how we do with this. But we will start modeling some of those jumps between, say, moderate elimination to tight suppression explicitly over time. Now, what we've got, Tom, and everybody else behind the scenes here, is the model includes contact tracing. So it does include what we think is the best reflection of what we currently do for contact tracing. It also includes in there that if your numbers go right up, your contact tracing will get less effective. What's not in the model at the moment is the intensity with which they're doing it in Brisbane to really stamp it out before it gets a hold. So in the future, we haven't talked about this amongst our group yet, but we could actually put switches in there for changing level of contact tracing and therefore isolation. At the moment, people are assumed to go into their home, be isolated. They have a compliance of, I think, about 90%, something like that. So we've built in all those types of things. We can pull those to the front of the model if there's particular interest from policymakers. At the moment, they're in the back of the model. They're as part of the whole way it works.
So this is a question, again, related to current policies and how they could be adapted. From Allison. Allison is in Howard Spring, and he's been in quarantine now, but he's actually already been vaccinated with J&J vaccine in the US. Can he come out before 14 days? What do you think?
Okay. All right. So this is the whole thing. The risk of somebody bringing the virus into the country is a three-step process. The level of infection in the country they're coming from, the level of resistance in the country they're coming to. So that's us. We're not resilient yet. We haven't got much vaccination. And then the nature of the traveler coming between them. So if you're coming from the US with really high infection rates and you've been vaccinated, your chance of carrying the infection or the virus reduces, but you've still got that much chance, which may be a damn sight more than if you traveled from China right now because there's no virus there. So unfortunately, Alison, your partner still has a chance of carrying the virus, even though they are vaccinated. It is much less than if they hadn't been vaccinated, so it's good risk reduction. And I suspect that by the time we start vaccinating 53-year-olds, that's me, for another couple of days, we will get to a point where we'll say, okay, if you're vaccinated, let's reduce the risk and we'll allow you just to do 7 days. And as long as you're clear on a test on 5 days, that sort of thing, we'll do it. But we're not at that point yet, in my view.
So here's a question about vaccine hesitancy. So how concerned are you about vaccine hesitancy in Australia, particularly with AstraZeneca, because of the suspension and restriction of use of the AstraZeneca vaccine elsewhere?
I'm hugely concerned. Where to start? I think it's very unfortunate the way that AstraZeneca has done their media stuff. They haven't done themselves a service with their portrayal of the vaccine by giving mixed messages. I think it's very unfortunate that the European countries actually stopped it on reasons that were not substantial enough to stop it. And what that does is it causes concern amongst the population and therefore spilling over into vaccine hesitancy. I just hope, I have trouble myself working out how to do media communication on vaccine hesitancy. But I think the best thing we can do is just be honest about the facts. And, here's a tool to see what would happen if we don't get vaccinated. That's useful. And to just keep reinforcing that as more of us get vaccinated, and we know that our uncle got vaccinated and it was fine, I believe we will see that vaccine uptake go up. My major concern is about kids, because we haven't yet licensed or approved the vaccine for children. When we do, the benefit to the child itself of being vaccinated is not that much because they don't get that sick. The benefit to the community is huge because you make your population more resilient. So we've got a very interesting discussion coming up about July, August, I think, of what happens with children, because that's quite tricky.
Definitely. Can you say more about the implications of asymptomatic transmission for your model?
Yeah. Okay, in the model, we assume, I think it's currently 30% of infections are asymptomatic, and it varies a lot by age. So it's a lot more at younger ages. And what that means is that person's not going to present symptomatically, so they're not detected and they're out in the community more. But once somebody who gave it to them or they gave it to them is identified, they become part of our contact tracing, catching mechanism. So it's built into the model at about 30%. However, there's a paper just published in The Lancet only 3 days ago, I think, which showed in Wuhan, where they went back and serology tested everybody, that the asymptomatics were even up at 80%. Now, I just can't believe that's true. I think what's happening there is you've probably got fear of citizens saying that they were symptomatic because of an authoritarian state. So there still is a lot of uncertainty about that asymptomatic percentage. What I can say is if you vary 30%, 50% or down to 15%, it doesn't make too much difference to the model. It's still important, but it's not too much of a problem if it varies around that, particularly if you've got good contact tracing.
So how much of the evidence base relied upon is from the West? So this is a great question, actually. How much from countries in our neighborhood who've been better at controlling the pandemic? So, there seems to have been a very different pandemic depending on where you live. And not all of these places are islands. So what are your thoughts about that?
Okay, this is a great question. So where to start? We built this model, Jason Thompson did actually, and g'day to him if he's on the call. He did a great job, and then we've extended it. It was built for Australia, and it was used in the roadmap, and it predicted things. So it's got predictive validity. Now we've added extra functions to it. We've brought in all the hospitalisation and the mortality rates observed in Victoria. So it's actually using Victorian or Australasian data. And we've also modified the infection fatality risk, all that stuff to be Australian. So we have actually reduced the amount of international data going into the model. It's mostly homegrown at the moment, but there are some things like that percentage asymptomatic, the tools that you can play with. You can decide what you think they are, because we still don't know what the reduction in transmissibility might be. But the last thing I'd say is we have done a lot of calibration on this model. So before we actually run the scenarios through the model, with the updates we've made, we check that it does actually reproduce an R0 to 2.5, 3.125, 3.75. And we check that if you're in stage 4, it reproduces the % per day reduction we saw of infections in Victoria. And we check that stage 3 with the old variant, 2.5, is still less than 1, because we know that that will slowly bring it down. So we have done as much as we can to calibrate and validate, but we need to be humble. This is just a model. It should be useful for thinking. I sometimes talk about myself as being an SQS expert, structured quantitative speculation. We have done our best to structure what we think is going in there and to parameterize it honestly. And you can see it all. If you're a geek out there, you can go and look at all our stuff on GitHub. And we would welcome criticisms, if you like, if you think we've done something wrong, and we'll have a look at it.
All right, so then in measuring health impacts of lockdown and COVID, you've included the long-term impacts of lockdowns on social determinants like education, employment, breakdown of social networks, families, longer-term substance use. I think, have you included these long-term impacts?
No.
That will also affect health. They're very important things. So what have you done to include those?
Yeah, love to do it, but just too much of that speculative part of speculative quantitative speculation there. So what we've done is we've worked out.
Well, you'd have some data on domestic violence, for example, Tony.
Yeah, yep. Okay.
There's data on that. There's real data.
Yep. So intimate partner violence, we've got the effect size, but what we've done so far, because we're building this as we go, and we're showing it to you early so you can see it. So we've only included the diseases that have a direct association with literature from lockdown. Now, intimate partner violence and physical activity have associations, but they're risk factors that then need to be linked to the diseases, and we just haven't got that in there. So intimate partner violence going in next with physical activity with its long run effects. But this is not a global economic model. We are not including in here the long run effects of scarring on your community, legacies of unemployment among youth. It's just beyond what we can model. What we will be doing though is we'll be putting in the GDP impacts for a week of lockdown, not a week of lockdown, so you can at least see that. That's coming up. That'll only take us about 3 or 4 weeks to get in, all going well. But it's got a limited time horizon. We just can't do better than that. Sorry.
There's been a lot of competition among states about contact tracing. Victoria has been criticized for not having effective methods. Can you tell us why, and if anything has changed to remedy that? And I guess I would say if kind of the differences in effectiveness of contact tracing have been modeled and put into your model, if varying approaches. I know you said that you've looked at kind of how tight the approaches are, or how you're doing contact tracing, but here it just seems like there's a difference in effectiveness, period.
Right. Okay. There's 2 questions in there. Is contact tracing variable by states in Australia? The honest answer is I don't know, because I'm not inside the Beltway. It obviously was inadequate in Victoria initially. I'm assuming, and I think it's a reasonable assumption, that it's pretty much the same level and pretty good across the states. Right. Into the model. If we make the contact tracing worse, we do see quite a degradation in performance. Now, Tim Webster's on this call. He's the guy who really made this AVM fly, taking it on from Jason. Tim, I recall, you might want to put something in the chat, that when we reduced the contact tracing, we didn't see nearly as much of an R reduction. So we did tests where we had it calibrated to 2.5, 3.125, and 3.75, and then we just put one intervention at a time to see what happens. And we put the contact tracing, and it made a big difference, as does masks. So if the contact tracing is not as good as what we put in the model, then there would be less reduction in that R0 going forward. But we haven't pulled it out as a switch onto the front dashboard. It could be done. I don't think it's the next best thing to pull out as a switch onto the dashboard personally.
So then we have talking about politics and practicality of convening a uniform approach across jurisdictions in Australasia. Yeah.
Okay, so this is well beyond the model, but hey, I've talked about this a bit, so why not? As a Kiwi over here at the start of the pandemic, I was stunned at how disorganized Australia was. So many different rules for each state and territory. I've actually come to admire it because each of the state and territories behaving their self-interest has actually worked quite well. And if we just had the federal government deciding everything at the beginning, I don't actually think we would have eliminated.
No.
So whilst it's messy and it's an ugly dance to watch, it is actually quite effective.
Yeah.
And so I've been talking a lot to the New Zealand population at the moment through media interviews over there. And I keep saying to them, yeah, it looks ugly. I know, I get it, but actually it works quite well. And from New Zealand's perspective, you'll just become another person in this crazy chaotic dance, but you retain your autonomy.
In measuring health impacts of lockdown COVID, have you included the long-term impacts of lockdown on social determinants? I think we've already talked about that a little bit, but you know, there are some numbers that you can have. Like there's some numbers you can get, Tony, and we talked about too, the exercise and the domestic violence, the intimate partner violence. But you know, really, it would enrich this model. So what are you going to do? And this will be the last kind of comment. What are you going to do to make this model better by actually trying to model the full impact of this disease?
Yeah, thanks, Nancy. I know we haven't done very well to this point, so, you know, I'm chastised. It's hard to do that.
It's got to be perfect, Tony. It's got to be perfect.
I've had so many people walk into my office in the last 15 years saying, Tony, you're now modeling interventions, because I used to do health inequalities, and I still do, by the way. And they're saying, why aren't you including income in your models? And I keep saying to them, because it's really hard to trace all the income effects through. But we are now reaching back in our non-COVID modeling to include housing, and also urban environments and bringing that through. So we are inching that way. In this particular model, we will be adding in the GDP effects, but it will just be the GDP effects for that short term. Bronwyn Croxton's on this call somewhere. She's the chief economist at the Ministry of Health, and she's heard me say this before. I've said to Bronwyn, yeah, we could do that. But at that point, I give it to Bronwyn's in the Ministry of Health. I say, Bronwyn, here's our model. Now, when you go and talk to the people in Treasury, use this as a starting point, and then you can add on what you think the long-term effects will be. And so I say the same to the new Australian policymakers, is that we've done a good job in the health space, but you are going to have to add to this if you're sitting in Treasury or the Department of Prime Minister and Cabinet, because there's only so much that we can do.
Well, I think there is much more that you can do. Obviously, you need support to do that, because your team needs to be able to have the time to be able to do the inputs that are needed. I think it's a tremendous model, and hopefully you'll continue to be supported as you refine it, Tony. So I'm sure that we could go on for a long time, and we've already gone over time. Thank you for everyone for sticking with us and getting through this, the really fantastic questions the audience have sent in. We're at the end of our webinar. I'd like to thank you all for making the time, for sharing the gift of your time to join us this morning, and to Tony for showing us how this new tool allows us to explore how different scenarios can affect the spread of the virus. If you have any questions about what you've heard or seen today, please contact Professor Tony Blakely. His email will be posted in the chat for you. And if you'd like to stay in touch and hear more about events like this, follow us on Twitter at UniMelb MSPGH. We have regular webinars and public-facing interactions. So I really welcome you to join our community. I hope to see you again, and bye for now.
Bye-bye.